Okay, so I'm gonna just start with a couple announcements first. I know Chris is he's gonna join, but he also does have to drop off a little bit early for an emergent NIH meeting, I think he said, but he should be popping on. Um, let's see, I just wanted to mention a couple things. One, thanks to everyone for submitting your engagement plans. And I believe by now everyone should have received some written comments from Chris. I think if folks have an opportunity to review and look through, we're asking for everyone to submit another iteration sometime in mid-September. And you can send.
Jeannie, only half of the engagement plan only half of the scholars received their engagement plan comments. Other half will receive them, I think, tomorrow.
Okay.
But all of the scholars should have received comments on this scholar development plan.
Yes, that came from Antonio. Thanks, Chris. Sorry about that. So if you haven't received it, you will shortly. And then you can work on iterating again, and you can submit it again in September. Antonio should have sent comments on the scholar development plan, and that's an annual update that we asked for. So we'll be asking for those again in December, January sometime.
Let me make a couple of comments about both. I just wanted to thank you all for spending so much time on the scholar development plans. I spent hours on them myself. It's actually a really great document for communicating who you are professionally and also what you're hoping to accomplish in terms of your career. One of the things that I commented on consistently across, and I think it's because of the way we organized it across the scholar development plans, is your area of specialization. And what we're really looking for is the area within learning health system science that you feel by the end of the 2 years, you'll have expertise in, not your weakness, not what you're doing now. So the program should give you the skills that you need to conduct learning health system science as an embedded researcher in the future. You also all have content areas that you're becoming expert in. But there's also, on the methodological side, it's really important that you finish with depth in one area. It can be engagement science, it can be implementation science, it could be an area that you develop. Like we just gave you examples. So the idea wasn't to pick the areas that you like or the areas that you want to focus on. It's really at the end of the program, what can we say about Nate Pager, for example, in terms of his learning health system science skill set? How can he, in an elevator, talk about who he is? I'm a learning health system scientist with expertise in pulmonary medicine and critical care medicine and special methodologic expertise in A, B, and C. So that's something just to pay attention to. We want you to define your area of specialization in your scholar development plan. And also there are other comments I gave each one of you, but thank you. It's really more a way of communicating to us exactly where you stand now and where you hope to go in the future. On the engagement, there is a lot of variation on the depth to which you all took the engagement plans. So that's why we're asking for some revisions by the middle of September. We're going to pair off as well. We want you all to see each other's engagement plans and learn from each other. Some of you, there's a couple of engagement plans that are outstanding, like their R01 fundable level. Others, which really need a lot of work, quite frankly. And what we don't want you finishing this program without knowing how to do engagement. And so this is your opportunity. So we're really going to press on this. It's a critically important area. So bear with me as you read my comments. We're only trying to help you develop that skill set, which is so important for your future work as an embedded researcher.
Thanks, Chris. I guess while you're already speaking, do you want to make a couple comments about the ARC meeting? I wasn't sure if you want to make any reflections.
I mean, I don't really have any comments. Be curious what the participants. I mean, I will say thank you to all of you who participated.
Yeah.
Some of you gave great talks. Sam and Gina both spoke, and they were outstanding. They got a lot of positive feedback. I got feedback about the feedback, so that was super. Some of you participated in just as observers, And thank you for doing that, because I hope it was valuable, and some of you participated in the small group sessions. The program directors are really committed to trying, assuming that we can move to a face-to-face mode in the future, continuing to convene you as scholars across programs. We think that our program director meeting should have a focus on scholars. So I'd be curious what people thought about the virtual content and what you would think about future cross-center meetings. Typically they'd be held at ARC in Rockville, Maryland.
I can just quickly comment. I thought it was great. I definitely learned a lot. I've definitely found virtual meetings. I would strongly support the in-person. I think there's always things that seem to crop up on your schedule that would not if we were physically out of our homes and offices. So I was sad to miss parts of it. I did, but I thought the parts I saw were great and really interesting to see the bigger picture of what's going on.
Yeah, thanks. You're absolutely right. It's very easy to schedule over a virtual meeting than it is when you're 1,000 miles away. Gina, Sam, anything to say about, you guys were a bit more involved because you presented?
Yeah, no, I liked the structure a lot. Actually, on the second day, I think really liked having the group kind of breakout sessions and having an opportunity to collaborate with others. I wish that had been able to be a little bit longer, honestly, because I think there were so many people per group. I think maybe a little longer and maybe slightly smaller groups, I think would have been helpful just to make sure that everybody got a chance to kind of open a dialogue and talk with one another, but in addition, get advice from the many mentors that were there. But I found that session really helpful. And I think, yeah, it was an awesome opportunity to hear what other scholars are doing and kind of see how their programs are structured and supporting them.
Mm-hmm. Great. Yeah, I thought the small, so-called small group sessions were large group and rushed. I fully agree with you. That was one of my comments. Samantha?
Oh, Sam, I'm sorry, Sam is not on today.
Okay. And anybody else?
Yeah, I had a comment. I always have a comment, Chris.
Yeah, I know. Alan was an active participant in the chat box at the meeting.
Yeah, so I thought that obviously our scholars did great. In general, I thought there was enormous variability in the nature of the work presented and the stage of work presented. The stage of work presented, I have no problem with. It's hard to everybody to do what they maybe intended to with COVID and everything. But the range was so broad that I was left wondering, what is learning health system science? Yeah. And I don't think, to be honest, Mark has a clue. I didn't get any sense that they had any parameters about what was in their mind, what they intend to have learning health system research look like. So that, I said before, I thought that's an opportunity for us to contribute to the learning by sharing our own perceptions as a pediatric group with what it is and what the range of possibilities are. I always think learning is best when it's formalized in a way to take what's seen and heard and turn it into something that's more refined. And I didn't see that process from AHRQ. They're great people, I know them well, but I didn't see that. I didn't see a structure for how that would happen or help us understand what they're looking for. Maybe they don't, maybe they just don't know, which is fine, but then we have to learn.
Yeah, I think it's the latter, Don. Honestly, I think that they are in a learning mode on this, but no, that's a point well taken. Other comments? Okay, Jeannie. That's good on the arguing.
Sure. The only other announcement I wanted to make was just pointing out the capstones, which will be happening this fall. So this is actually kind of a wrap up for cohort 1 for our 10 scholars, and you should have received holds, I think, on your calendar. So it's scheduled for October 7th and 21st. I believe that's a Thursday. It's a 2.5-hour session. It'll be taking place at the learning sessions. So we do expect all of you, cohort 2, to attend both of those sessions. And so we hope with enough time in advance, you can make sure you set that block aside. The only other point I wanted to make is that for the rest of this calendar year, you can expect sessions on the 1st and 3rd, as we've been regularly doing. The next time we'll be meeting is on the 21st of September, because Labor Day falls on that first week. We may be adding one in because we're losing kind of half of September and because of the capstones, but we will let you know when that would be, if we're going to be doing that. Okay, I think that's it in terms of announcements from me. So at this point, I want to turn it over to Dawn. So today, what we wanted to do was really focus on talk a little bit about the personal quality improvement projects, and the purpose of this very specifically was to help us think about key concepts in QI and tools and skills, learn how to apply them, and rather than focus on kind of a clinical project, which would have a lot of externalities or things that might make it difficult for one to implement in your healthcare setting, to make it a personal quality improvement project. And so we shared an example of a charter with you, and Dawn is going to talk a little bit about some of the key concepts and comment and reflect and help us through a discussion. So with that, I'm going to turn it over to Dawn. You're muted.
Yeah, I'm not going to be very long-winded about this, because I think the example that we sent out pretty much speaks for itself. This was the one on the jazz improv. Yeah. So I have some confidence this is a good exercise, because we've been doing it for 4 years now at the Harvard School of Public Health with people who are generally post-grad, physicians, nurses, whatever. So I don't have any personal doubt that this is hard to do or that it's not appropriate for this group. What always amazes me is the quality of the work that is done on these projects. You know, it's a elective credit course at the Harvard T.H. Chan School of Public Health, and for some people are taking it as pass-fail, and some people are doing it because they need an elective. I don't think everybody has the same level of intensity on getting an A or an A+ on this work. So they're basically taking this course because they want to learn about improvement science. And just to give you context, it's 15 weeks, 13 of which are actual looking at videos, studying, reading, and then the last 2 are prep for finals and a kind of open to everybody interview over equity. We had a wonderful debate about COVID and equity with Ron Wyatt, who's a real advocate, I think, for equity and the rights of African Americans in particular. So the first 7 weeks of this course is exactly the Harvard X MOOC, which is what you're going to be taking. Gina, you can remind them on what their timeline is on that, but the first 7 weeks was put together about 4 years ago now with Harvard X. It's the basics of improvement science with folks like Don Berwick and some other guest faculty, and I'm on there. I had the opportunity to review it in preparation for transferring some of the content to Imperial College in London, where they're setting up a similar course. And it held up. There was nothing there that I looked at and said, well, that got dated, because basically improvement science doesn't get dated. The concepts are so straightforward and simple and logical that I can't imagine when or how it would become dated. There are some addenda to that, especially on measurement, which I think will be helpful to you. And I hope that the version you self-pace through will have access to those. I checked it, I think it does. If you don't have the extra material, especially on measurement, then you should let us know if for some reason it's not working. There are, as I recall, 6 or 5 pieces to it, each of which deals with different aspects of measurement. And it's critically important for what you're doing with your personal improvement project, which requires a measurement framework. It also is designed to pace you through your personal improvement project. It gives you concepts kind of in the order you'll need them to do what's required for your personal improvement project. So driver diagrams, measurement frameworks, plan, do, study, act, all that stuff is iteratively discussed in the expectation that you'll be doing homework of posting pieces of your personal improvement project, or at least doing it on your own. So I read the ones that have been submitted so far and elected not to comment because I think that there's room for improvement in all of them, although one or two of them were actually quite good and really, I think, followed the standard set by the Jazz Improv Personal Improvement Project. Others, there are a few points I'd like to emphasize really for everybody. First, the aim statement, the how much, by when, for whom, really is key. And being quantitative and explicit is really important. So if you're writing a NIH grant or a PCORI grant, and you had an outcome that you wanted to specify, you would be very, very explicit about the definitions, the criteria for that outcome. And so for a personal improvement project, it's the same thing. I remember one, which I thought was really interesting. The person wanted to have more fun. And I kept asking him, define fun. How are you going to measure fun? What is fun to you? And gradually we worked out something that was not all aspects of fun, because it's a personal improvement project. You can't make life fun and have an explicit aim, but he narrowed it down to things he really thought were fun and he was going to work on, and had something to do with time outdoors with his family. I can't remember exactly, but time outdoors with the family is not a measurable aim, right? It's got to be by July 2022, I will spend at least 5 outings with my family per week of at least an hour duration. I'm just making that up, but that would be a measurable, explicit aim for having fun with the family. Hold on just a second, I'm getting pinged here. Oh, it's okay, nothing. Whenever it's my daughter, I like to pay attention. That's my daughter. And then obviously a date. Now for an aim, it really helps to have a baseline. Now I understand in your improvement project, you may or may not have a baseline. One of you wrote, right now I'm doing 0. Okay, so your baseline is 0. And if you say, I'm going to improve to some goal or improve by some percent, it helps to know the baseline. So if you can even estimate the baseline or collect a few data points, that's great. Then you can say, I want to improve from an average of 1 outing of 1 hour per week with my family to 5 outings for 1 hour per week with my, whatever it is. Then I can get some sense of the magnitude of the challenge, right? If I don't know the baseline, then how do I look at it and say, well, is this really realistic, achievable or not? So is that clear on the aim? Specific criteria. You may have to narrow your focus to be the best person on earth by 2022. Okay. And it's not an all or nothing. It's not, okay. I'm trying to remember what one person said, but I'll give you an example. It's not, I will go to the moon by 2022, because there's no interim measures that are specified there unless you supply them. So having some outcome that's a little bit more granular than I will go to the moon is probably a good idea. If you go to the moon, that's great, but then I'll want to see the process measures. This brings me to the measures. And in almost every year, there are a number of students, so you're not unique, but a number of students who don't actually get the idea of a process measure right. So I'll take a volunteer. If somebody wants to tell me, what is a process measure? Let's say my goal is to become much more fit. Specifically, I want to be able to run the 1 mile on the beach, Gunkwit, by the end of the summer. What would some process measures be for that? What can you imagine? Take, or whatever your aim is. What is the goal of a process measure?
I think the process measure is meant to be something that gives you some rapidly measurable interim assessment of progress. So for the running example, it'd be total amount of time spent running, total number of workouts per week, interim times on something that you could run an 800 3 days a week and chart those times and give you some marker of measurement towards your end goal.
Yeah, exactly. So and here's where people get hung up and they don't need to. Some process measures could also be seen as interim outcome measures. So let me give you an example. I may have mentioned this before. I can never remember which group I said it to, but let's say your goal is to improve blood pressure control for young Black men in rural Alabama. And you can define the population in such and such a county, so many men, whatever. And your outcome then is blood pressure control for people who have hypertension, meeting national standards for young men. And that there is a specific, I don't know if it's 120 over 70 or 80, I can't remember for young men, but something like that. So there are some key processes, right? You have to, first of all, screen them for hypertension. So a process measure is your goal for screening people for hypertension, knowing that if you don't screen them, then how are you going to control their hypertension? And you can imagine a number of experiments and changes, and we can talk about some of them later, but that's a good process measure on the way to the outcome of blood pressure control. Then you might have another process measure for people who have an appointment with somebody who can actually give them a medication. And another process measure might be prescription of evidence-based hypertensive medication for this population. Then down the line, it might be adherence of the person to the regimen you prescribed, because you can't control their blood pressure if they don't adhere. So all of those are on the causal pathway, your theoretical causal pathway, from whatever changes you think are important to getting blood pressure control in a population of Black men in rural Alabama. And being very explicit about where they fit on that causal pathway. So you could draw a diagram, call it an acyclic diagram or DAD, or you want to read Judea Pearl, you can read more about causal pathways and how to describe them, but they ought to fit on that pathway, with the thing on the far left or the far right being the outcome of interest. Now, where people get needlessly hung up, they'll say, well, I think getting men on medication for high blood pressure is a really important outcome. I mean, it's a process. It's something I did, and it's on the way to getting blood pressure control, but it's a really important outcome. And I'm happy if you say it's an intermediate outcome. I don't get all hung up on the terminology. I think screening in itself is better thought of as a process measure, but maybe in your population, getting them screened is so challenging that will be your intermediate outcome. As long as you can clearly describe to me or your buddy what the causal pathway is to get you to your outcome and where these measures fit on it, I'm happy. Is that pretty clear? Nathan, I like your example. I mean, there's certain, like when I'm trying to lose weight, an intermediate process measure would be the calories I take in per day, or did I actually even do calorie counts, or did I do what I said I was going to do, which is stop drinking so much wine at dinner. So all those would be process measures on the way to losing weight. Did I test you on this? Chris, how many calories are there in a glass of red wine, and what are the confidence intervals around that?
A glass of red wine. Oh, I'm sure it depends on the grape, Don.
Not really.
I have no idea. 250.
Who knows? Leanne.
250.
How many? He said 250. What do you think?
250 for 3 ounces.
Well, it's about 70 to 100, I'd say.
Yeah, so it's 150 to 200, and it depends largely on a standard pour. And red wines can vary in alcohol content by several %, which is why there's the variation. So it's not the grape, it's the way in which it's processed and handled. Anyway, so But that would be knowing that would be part of my process measure for knowing how I'm doing in my calendar. So
Don,
that's, yeah.
Before I go, I just have one question I wanted you to elaborate on. You're using the phrase causal pathway, and in research, there's in journals, they push back on causal inferences, and there's a whole area of causal inference, without randomized trials and that sort of thing. What is your sense of the definition of a causal pathway for an improvement project, and to what degree should scholars look at the evidence linking maybe their process measures with their outcome?
Yeah, so a causal theory is a theory, and you can call it causal inference. Judea-Pearl's work's all about causal inference. But it expresses a theory or a hypothesis. All of quality improvement is based on hypothesis and prediction, right? And in quality improvement, you almost never have complete certainty, and you very rarely have complete confidence in your causal theory. But you're trying to build towards that. And a lot of sloppy quality improvement's done because people are afraid to use the word causal. They're afraid to move from association or relative lack of evidence to something that they commit to. And here's an example. I may have given this to you guys before as well. Let's say I want to put together my causal theory as expressed in a driver diagram with process measures and an outcome measure of reducing surgical site infections by 5% in clean surgery in children between the ages of 5 and 15 at Children's Hospital Philadelphia by July 2022. Now that's a pretty good aim. That all it lacks is, I know right now that the rate is 2%, and I want to reduce that by whatever I said. So, and your idea, Chris, your big idea is, I think that applying a alcohol-based chlorhexidine prep solution to the surgical site, that's what I need. And I will say, well, there's actually a fair amount of evidence for that. Nothing in children, actually, almost exclusively in adults. And what I'm now going to ask myself to do is, if that's the one thing I'm doing, what's my prediction about the attributable fraction or the amount of change I can expect in the outcome of interest along the theoretical causal pathway? And as I examine that and do a Judea-Pearl type exercise, I'll find that the skill of the surgeon, the actual age may vary between 5 and 15, whether it's appendectomy or herniorrhaphy, all those things matter, not to mention the things I don't even know to measure, like teamness, which is very important in the surgical suite. So my attributable fraction actually on my causal theory might be that, and the best of circumstances, totally reliable, 100% adherence, it'll be it'll get us 15% of where we need to be, or 10% of where we need to be. So it's just being very explicit about how certain are you. And if you're honest with yourself, you'll put confidence intervals around your estimate. So maybe it's between 5% and 30% attributable fraction. So my colleagues talk about this as a degree of belief or confidence in your theory and prediction. And that's all it is. If you're honest with yourself, you'll notice on the template, when you suggest a change, I've asked you to give, I think on a scale of 0 to 5, your level of confidence that that change will have the desired effect. That's your putting in a little envelope, a piece of paper saying, this is my prediction, and I'm going to see how close I am to making that prediction reality. So I hope that's clear. A lot of people call this change theory. A lot of people call it program theory. I don't care. To me, it's all part of my attempt to get from hunch to a sense that I'm close to causality here. Okay, so that's, Chris left, but he chatted. He said it was an okay answer, so I'm happy now. Got through the aim, the process measures, the outcome measure. There's this other thing we ask you for, which is a balancing measure. So who wants to deal with this one? Gina or Paul, what's a balancing measure? If you don't know, what does it sound like to you?
I think of it as an unexpected outcome, like a like a negative outcome that could occur as a result of a QI study or project?
Yeah, it's an unanticipated, almost always undesirable outcome. And the key here is to think about this carefully beforehand, looking at your causal theory and the system you're trying to improve and say, if I do this, what's a unexpected thing that could happen that I better be aware of now because I'm going to want to monitor it. And failure to do this is actually, I think, unethical. I mean, if you don't know what what you can predict would be negative outcomes of your study, how can you say you don't need to go to an IRB for your quality improvement study? So let me give you an example. And I really apologize if I said any of this. I have 4 different fellowships I'm playing with right now, and I can never, plus a course at Harvard, and I can't remember who I said what. And then I talked to Leanne offline, and I may have said it to her, but not to all of you. So let's take something really cool like MRSA, methicillin-resistant Staph aureus, which you all know about, right? And we're concerned that in the intensive care unit at Boston Children's Hospital, we're not isolating patients enough who we know have MRSA because of screening for it. We really want that to be 100%, right? How could you possibly countenance going to a parent and saying, well, we know that MRSA is a danger here and people die from it, but our isolation precautions rate here is about 91%. I mean, that would be an interesting conversation, right? So your quality improvement project is to go from the current rate of 91% up to 100% of isolation of patients with MRSA. Does that sound good? Roland, what do you think? Is that a good thing? You see patients and relieve their pain and so forth.
It's impossible.
Oh, please, that you can't say that. It's not impossible.
It is true.
It may be unachievable, but it's not impossible.
Well, that's the approach I'm taking, is the infrastructure necessary to do that. Plus, at Children's, we don't test any of the providers for MRSA. So it would involve very large systemic investment.
Whoa, stop. I didn't say eliminate MRSA. I said getting 100% of colonized patients on precaution.
Right, but that would mean at any point they traverse the health system, they would have to maintain that precautionary status, correct? So
I said it was in ICU. The ICU where your department has Aegis.
Sorry, I'm just taking the entire perioperative.
No. I was very clear. I said in the ICU. All right. Well, let's not argue.
Okay.
So let's say that I think that I'll give you do obeisance. Let's get to 98%. You think we can do that? Quality improvement. This is improvement science after all. You got to say yes. Just say yes, please.
Potentially achievable goal.
So what are the unintended consequences of that? Mike, what are some unintended consequences of that highly ethical, good thing to do to get people who should be isolated?
Well, you're going to have to potentially.
No, Mike's going to answer this.
Okay.
You're off the hook.
I was thinking, I mean, to some of the, sort of referenced earlier, but it'd probably take a lot of effort. So is that the best use of whoever it is, nurses or MA's time, making sure we have that 98% compliance, and do we get enough benefit to outweigh the risks of that might be distracting them from more valuable work they could be doing? That's one thing I was thinking about.
Okay, opportunity cost, in other words, right? The time of the staff. So how long does it take to gown and glove and mask, or you don't have to mask in this case, but gown and glove to go into the room and then take it off and practice hand hygiene where you're supposed to?
Probably like a minute, or less in best case, depends on size of your team also.
Yeah, well, it's not COVID. You don't have to put on a hazmat or something, but yeah. So people have measured this, and I can't remember exactly. I think it's 47 seconds or something. But if you have an ICU full of people on isolation, which at Boston Children's almost everybody for something, right? Some virus, MRSA, we don't know what it is. We're worried. The surgeons are scared, whatever. You add all that up, and the number of times you go in and go out, it's a massive amount of time. So opportunity cost is important. Anything else? Somebody else? Antonia, anybody? Jeannie?
I think patient satisfaction is probably a factor. Patients are getting
Yeah.
swamped a lot more and are kept in isolation all the time.
Yeah, so it turns
Yeah.
out studies have shown that patients feel stigmatized, they don't always understand. And then additional studies show that nurses and doctors don't go in the room as often to do things they should do, like check whether the Foley bag is above waist level or whatever it might be, measure the urine, take a blood pressure, make sure the patient's not dead. So stigma, isolation, and in fact, substandard care. So the Joint Commission says that patients on isolation precautions should get exactly the same care, quality of care as everybody else, but several studies have shown that doesn't happen. And then what's the final consequence of 98%? What does it cost? A disposable gown, gloves. It all adds up if you're doing it hundreds of times a day in an intensive care unit. So knowing all those things and either mitigating in advance or deciding I don't care is really important. But if it's something like not measuring blood pressures often, then you probably ought to be monitoring that as part of your quality improvement project. Or if it's something to do with stigma, then you ought to be monitoring a process measure to reducing stigma, which is how often did the caregiver sit down with the family and explain the purpose so they wouldn't feel stigmatized in the language they can understand. So you see how this works. It's all part, the balancing measures are critically important and people usually get them wrong. To my horror, one of the experts at IHI, a senior vice president who does videos, you'll find him all over, I won't give you his name. I was checking out his content for the IHI Open School and I went to see his video on measurement. And first of all, he oversimplifies it by saying there's measurement for judgment, measurement for research, and measurement for quality. And all he talks about is measurement for quality, when in fact, everybody in this call, if you're in a clinical setting, knows that measurement for judgment and accountability is what occupies most of your day because people are watching you. Quality assurance folks are on top of you. But he described a balancing measure as not something unintended and undesirable, but as another part of the system that's affected by the change. And that's a very sanitized view of what a balancing measure is bad in general, not just some, like one of the examples he gave was some change was going to have a impact on efficiency of some other parts of the system that was better. So we call that a balancing measure. It's not a balancing measure. It's a unanticipated effect that's desirable in another part of the system, and that's great. Okay, so those are the measurement issues. Now, the rationale is actually important. And here's where what Chris said becomes important. If you think that, I'll give you an example. 2 students in 1 year had as their personal improvement project prevent the cat from barfing in the morning, because both of them had kids and they had to get their kids off to school and make them lunch and all that stuff. And they'd come down and the cat had barfed and they had to clean it up. And I know this, my wife's been in Vermont for 3 days and the freaking cat barfs and I got to clean it up now, right? So I'm very aware of this. So if you think that a good change would be to feed the cat in the night before 7 o'clock in the hope that they won't barf in the morning, you better have some evidence for that. Otherwise, it's a hunch and you're going to just say, I don't have any confidence in this, but it seems like a good idea. It seems logical. And so you'll rate maybe out of scale 5, a 2, it makes sense. But if you have 3 studies showing that feeding cats late in the evening causes barfing in the morning, especially if they're Maine Coon cats, then you should state that so we can adjust your degree of belief or your prior probability, as they say in Bayesian science, in the cat not barfing. By the way, if you understand Bayes' theorem, you understand most of what prediction is in quality improvement. It's all about your prior probability, your prediction that your causal theory will work and that the changes on your causal ramp will have a desired outcome. So those are the main things. And then we want you to start talking about barriers and challenges. I call this an anti-driver diagram. Some people call it a force field analysis. I think I briefly told you about what a driver diagram is, but I'll give it to you in a way it'll make it really clear. I won't have to say it again. So I was a kid during the conflict in Korea. And I'm choosing my words carefully because teaching a course in social injustice, which I now do, and saying the Korean War or the Vietnam War really is offensive to people who live in those countries because especially in the war in Vietnam, as you know, it wasn't the Vietnam War, it was the American war in Vietnam, or the Allies war in Vietnam. So very careful about that. But in the Korean conflict, the conflict in Korea, I would look at the war maps every day in the New York Times. And what color do you think the arrow showing the battalions and the movement of the Allied troops was? Black and white newspaper. It was white, of course. I mean, we're the good guys, right? So we're always white. And the commies, since they couldn't put them in yellow, which is what they did back in the 40s and 50s, actually, literally. I have a series of bubblegum cards called Fight the Red Menace, in which the Red Menace are very yellow looking people who are basically torturing and pouring boiling oil on white people. So anyway, that's my statement about equity for the day. So the white arrows are going north out of the divisions of the battalions, and they're real arrows. And then the black arrows representing the North Koreans and ultimately the Chinese were coming down to meet them. So a good general would imagine, where is the anti-driver going to come and what is my logistic strategy to make sure I'm ready when they do, or to evade them. And you know, if you guess wrong, you're in big trouble. So you'll remember that when the Chinese entered the conflict, they swept past the arrows going north and eventually outflanked and pinned the Allies in the narrow peninsula where they almost obliterated, had to be evacuated by sea. And because somebody had guessed wrong on what the anti-drivers would be, actually it was MacArthur, I think, who said, oh, well, you know, they're not going to come into the conflict, except they did. And all of his white arrows were not positioned to meet that onslaught. So that's the anti-driver diagram. Who are the arrows ready to meet you and foil you and destroy your personal improvement project? So one example might be, I'm going to get up every morning at 5 a.m. so I can do my exercise. Can't imagine where I got that one. One of you will recognize it. I'm going to do this 3 times or 5 times a week, whatever it is. And I've set my alarm so that it will go off at 4:55 in the morning. Well, for a married woman, what is the anti-driver for that theory? It's the husband not wanting the alarm to go off at 4:55 in the morning on the iPhone, which is set way too loud. I know this because I set my alarm for 6 o'clock most days when I have to get up and do something, and my wife likes to sleep till 8. So I am well aware of the anti-driver of my wife and my alarm being too loud. And why don't you keep it under your pillow, or why don't you use something that vibrates? So this is what all I'm telling you, whatever's going to get in your way. And then that'll get you to talk about the team that's going to help you with your project. And one of the most, I think, moving aspects of most of the personal projects that I've looked at from the Harvard School of Public Health, they always have tended, not always, but they often bring in a partner. It could be a significant other. It could be a favorite uncle who's going to call them. It's somebody to support them and provide an additional team to help them win. It's sort of like in a bicycle race, where you have the American team, and the one who's going to win is in the draft of the person who's going to be the enabler for the team or whatever. So thinking about who can get you to be a draft for you to be pulled along to your goal is really, really important. During COVID, it was astonishing to me what people revealed in their personal improvement project. Things about life altering, this is what it did, this is it. I couldn't get my project done, but in addition to that, I was despondent because I couldn't do this and many other things. So the impact, personal improvement projects are a lens on where you are in your life. And it's perfectly fine especially when your final summary of your project, to say, Well, you know, I achieved my goal, but now I'm looking back and said, at what cost? Because this was my singular focus, and I didn't think to measure it as a balancing measure. I didn't know how to measure it, but basically, I didn't pay enough attention to my family while I was busy getting fit, so I could run the marathon. So that's all. That was much more than I intended to say. I'm sorry, but I think any window into your own life and anything you're willing to share that will help us understand who you are as a person or family or friends, that is, I think, a treasure.
Thanks, Don. We can open it up and see in the last few minutes if people have any general questions about some of the comments that you made or something specific about your own project while we have Don with us.
One quick thing, at least one, I think two of you actually included something about your real project. I don't mean real as opposed to unreal, but the project you're doing for your research. And this is personal, right? So it really shouldn't be related to your major health systems project. You're all good.
I think what you shared was very, very helpful, Don. And for the few people who aren't on, actually, we recorded it so we can share it with them as well. I think just going back to Don's point about the MOOC, the IHI edX MOOC, that's something that we hope you started. I believe there's 7 modules, and they say that it's probably a few hours of time per week. So we're hoping over the next couple of months you can do that along with this project, because a lot of the, as he shared, a lot of the key concepts are discussed and presented and worked through inside the MOOC. So
yeah, one thing just to say, I don't know why, but most of us in that MOOC speak really slowly. I think maybe I was aware of an international audience, but they can be played 1.5 speed with no problem. And that'll get you through quick.
Yeah. And I know we didn't mention this before, but so I think this was a good time to help folks think about and revise as needed your projects. And I think Chris had mentioned he would like us to launch in mid-September, because I know things are kind of, people have different plans for the summer, so we don't want people to start and then not be able to do it consistently. So the thinking is you can revise your charters and we can launch the project by mid-September. And Don, I believe you said that we should aim to have this run about 12 weeks. Is that?
Yeah, that's what we usually do in the School of Public Health, yeah, and in Imperial College. One thing I should mention, because it always comes up, that you're required to put your data on some sort of run chart or graph, time-ordered graph, and always comes up, how small can my increments be? Like if it's something that you're measuring monthly and it's a 12-week project, that's 3 data points. You can't do a run chart. You can't really see how you're doing. So we try and break it down to the smallest feasible intervals, like a week is a reasonable interval for something like having fun with your family 5 times a week. The problem is if you break it down further and further and further, the sample gets smaller and smaller, and the variability gets larger and larger. So you pay the piper one way or another. You just have to come to something that is as often as you can to get a sense of how you're doing, but not so often that it's widely variable from time to time. So you wouldn't want to do it on a daily basis for almost anything, for example.
Don, should we be aiming for everyone to kind of resubmit their charters in mid-September before we kind of formally launch?
Yeah, we can do that. When are they supposed to finish the MOOC?
I think we had thought, by the end of September, because
so a little ahead of the due date for the project. Yeah, the MOOC requires that you do certain things related to your project if you're actually doing the homework, like submit your charter. So when the MOOC says, having learned about some of this, post it, then that's a good time for us to look at it. But don't get deep into your project without sending a revised charter and or at least that template. And the trick is it's never written stone. It's always malleable depending on what you're finding. So if you find, for example, that John, your best buddy, is no longer interested in supporting you in your marathon or rock climbing dream, then you got to have plan B and you change your charter accordingly.
Okay, then I think if we aim for folks to revise earlier, so like you said, that folks don't go too deep into it while they're completing the MOOC, we can do that. Get
I
feedback.
think you're going to have to trust me that when I say that if you do this, you will know, I think, everything you need to know about basic improvement science. There are other sciences that are really important to bring in, and some sophisticated concepts that we do in the Harvard School of Public Health around behavioral science, around interrupted time series analysis, statistical process control charts. But honestly, if you know they exist and you know who to call about it, then you will know most of the basics from just having done this improvement project.
Okay, great. Thanks, Don. Thanks,
Okay.
everyone. If you have any questions, you can reach out to us, but otherwise, enjoy the rest of your summer. And we look forward to seeing you in the fall.
Yeah, I have a personal improvement project I'd like to work on with your help. So every time I start out with something that I say is going to be really brief, I take the whole time. And the only thing I have a practice thing, which I think I either have done or will do with you, where I'm saying I'm going to tell you everything about improvement science in under 7 minutes. And I've now gotten it down, so I've never gone over 7 minutes in the last year. But I need to bring that to everything else. So if you can figure out a way for me to have a measurable aim, we can work on that.
Okay, the challenge is on for everybody.
Okay. All right. Very good.
All right. You, Don.
Take care,
Thanks,
everybody.
Bye-bye.
Bye.